Hi, everyone, and thank you for tuning into episode 7 of the Real Heroes Don't Wear Capes podcast. I'm Stephanie Carter here with Crystal Sutherland and Michael Weens from the HS Heroes team. And today we're joined by special guest Dr. Michael Cecchini. Dr. Cecchini, could you please introduce yourself to the listeners?
Hi, everyone. My name is Dr. Michael Cecchini. I'm born and raised in Timmins, Ontario. Undergraduate medical education at NOSM, Northern Ontario School of Medicine in Sudbury. Residency trained in Toronto, and now working in medical and surgical dermatology and clinical trials in Richmond Hill at York Dermatology and Research Center.
Thank you. And I think we can just jump off with what made you choose to take on dermatology as your specialty?
So dermatology, that's actually an interesting reason as to why I joined the bandwagon of wanting to become a dermatologist, which was a competitive specialty during my time in medical school. I actually had, and probably still do, have bad eczema, and it actually quite affected my quality of life. And it was something that I was very self-conscious about because it was on my hands. So it was always visible to people, and I was always very self-conscious, and I was always hiding my hands. And so I went to see a dermatologist when I was in medical school after many, many years of being untreated. And I took a liking to the specialty. The beauty of dermatology is that it's a mix of medicine, surgery, and cosmetic things like, using laser devices and fine tuning things like fixing scars from people who have acne, or like when we talk about HS, fixing scars, the color of scars, or minimizing the scars. So there's a lot of options, lots of breadth within one specialty.
So you just talked about lasers. I remember Dr. George giving a presentation at Shisha last year. Are you guys using them exclusively for scarring, or do you use it to help with inflammation and other kind of?
So that's a very good question. So I actually expanded on our lasers that we bought at the clinic now. Maybe even since anyone's been last been at our clinic, we've actually added a couple of them, and one of them is actually targeted against the color red. So it actually is used for example, scars are red, right? They're pink, okay? And one of those lasers that we have actually knocks the color out of that scar. So let's say someone has a wide scar or a thick scar that's both red and elevated. We could shrink the scar with using intralesional injections with steroids. Then we can further shrink it with our laser, which actually knocks out the colors. So, anywhere from a young woman who's got scarring in her groin or the armpit, when she lifts it up and it's still red from the scars, or a young male who's got acne, HS in the face and the back, we can knock the color out of it and get the skin texture looking closer to normal as possible. So our cosmetic stuff that we have in the office is used more so to correct the effects of medical issues that our patients are coming to us, with concerns.
Would you use that for like broken capillaries on the cheeks or like
Totally.
rosacea patients?
All that stuff as well. We do all as well, yeah. But we're interesting though, and most people would call me a bad businessman or a bad marketer, but we don't advertise any of our cosmetic lasers. We're not, when you walk into our office, there's no Botox pictures or anything like this. Everything's been removed off the walls, and I've got nothing in my office to promote that. And rather, I use it more so once I've already established a rapport with my patients who have a medical issue, who actually request something cosmetic. We're not the office that's, offering this and that when you walk through the door. We have a different approach as to how we market it and how we execute the use of our cosmetic devices.
And what
So
about if it's targeting red? What are the options for skin of color if that's not something that can happen?
That's an amazing question. That's a very good question. So the laser that we use is it's more sensitive and it's actually usable on darker skin types. So there's about 6 different skin types, and the IPL, which is a very classic pseudo laser that most offices will have as a cosmetic procedure, can only be used on the first couple skin types. After that, you need more of a specialized laser called ND-YAG with a different wavelength to it, that is more protective against skin of color. So the one that we have in our office that we use for scarring with color, it's actually safe in skin of color all the way up to about type 5. So right before the end of the line.
We learned at the Skin of Color Summit that we went to in the fall that they're actually changing the Fitzpatrick scale to add other shades that haven't been considered before. And we also learned that they're starting to redo diagrams for skin conditions because they were showing pictures of atopic dermatitis on infants, and you a lot of the warnings is red, rash, angry skin, and some red doesn't show up on skin of color sometimes. So I found that was really interesting too, that they were starting to change the way we look at skin.
Wow, you guys are, so I had no idea about this. So you guys just taught me something new. I've always wondered about that Skin of Color conference series that happens once a year. I have colleagues that went to it, but I never even knew about this switch. So I just learned something new. But
Come
one
in
thing that
September. It's on again in September.
is it the one? It's not the one in the Caribbean, is it?
No, this is online.
Okay.
Yeah.
So just to clarify and just to reiterate what I was saying is, with regards to the Skin of Color, is that you definitely need to use more specific lasers that are more targeted and safer for darker skin types. And we're becoming an office that is able to give a wide range of services to people of any skin type.
That's awesome.
A few months ago, I guess now, we were talking to Dr. Rao, and he was
Jaggi
saying,
Rao?
Yeah, Jaggi Rao. And he was saying when he was in medical school, the only things kind of written about HS in the textbooks were like, tell your patient to lose weight. And things are very different now. I wonder, as someone who's, a more recent graduate of medical school, what did you learn about and what do you wish they had taught you?
About HS?
Yeah, HS.
Nothing.
Really?
No. I mean, in my medical school, we were in a self-directed learning type of system. So basically, we had to learn by ourselves. And I had one dermatology lecture in my entire medical school, 4 years. We had small talks here and there from dermatologists, or from one in particular, my mentor, Dr. Lynn Giroux. We would have small lectures and small talks, in her office, for example, at the end of the day. But I literally did not learn about HS until my residency.
Do you remember the first time you saw HS, or I don't even know how you would word that? The first time?
Yeah, the first time I encountered it. Yeah, well, the first time I encountered it, was with one of my professors, Dr. Rayad Al Hussein, at Sunnybrook, and I mean, it's such a distant memory now, and I'm not even that old, but I don't even remember the encounters, because as a student, you're bombarded with, I got to impress, I got my staff doctor, I got to take the right notes, I got to do this and that. But I think the real awakening and the true reality check that I got was actually when I joined your dermatology clinic and I started seeing HS patients after Dr. Alavi had left. And I still tell people this today, that people do not understand like the burden of it and like the severity of the skin condition. Like if you look at research and development for psoriasis drugs, now eczema drugs, okay, they've been researched and they've been in the pipeline now for 10, 15 years. But if you look at the DLQI scores and how people are affected, and you put this beside other conditions, HS is way more of disease burden on multiple fronts. And that's in the research, and then it's also in clinical practice, because when I see patients today and I have learners in the office, or I have people from industry in the office who are coming to learn about HS, I still tell them straight up, I say, this is the worst of the worst in terms of inflammatory skin conditions that people are living with. And even there's days where I see new patients, like I just got off the phone today with a patient at the office on a FaceTime call, and she'd been dealing with HS and psoriasis and inflammatory bowel disease all in one.
Damn.
Yeah.
It's the
And
comorbidities.
and she has like textbook comorbidities that you all see in one person, and just even that is still a reminder to me. It's almost like the first time all over again. It's like a reality check of reminding me, what people come to the office, seeking help for. And yes, there are days where I've met patients where I was a bit quicker, but it doesn't negate the fact that I still understand how much suffering goes on for this condition.
I find that we feel that way too. Like there's times where we haven't had a flare in so long, and we hear other folks' stories, and sometimes you think, oh, is it really that bad? And then one of us will get a flare, and it's like, yes, it is that bad. This pain is all consuming, and it takes over your life.
I think that's like a key thing you hit on, and that's what I've been trying to drive home to learners. Like I said, I've been having industry people now wanting to come and learn about this, right? So there are new drugs that are coming through the pipeline into the market for HS, some of which I have experience using. And I'm getting these industry folks from these companies wanting to come to the office and see it for themselves. And this is the big thing I tell them. I say, like, this is so consuming. Imagine Band-Aids every day, changing dressings, worrying about the pain, not being able to go out for too long. All these small things that, we take for granted. And again, when I see a new patient who hasn't had help from the system, it's just a reminder, even to me, all over again about how much of a burden this is.
Just to touch back on medical school, because you didn't learn about HS per se, what do you wish they were teaching in medical school about HS, and maybe even people who are going into being
Family medicine, for example, of course. Well, it's very simple. What they need to learn in medical school, what I wish I would have learned, are some simple things. What are a couple different presentations? When to cue in from a history, right? Because 80% of the medical problem can actually be discovered based on a good history. That is one of the key things I remember from my first days of medical school I've learned. So there are a couple key things that you can pick up from the history alone, especially now where family doctors are not in office, where they're just doing phone calls. There are key things on a history alone that you can pick up on that can trigger you to think about, to broaden your differential diagnosis, and then refer on to the right people like us. So just to recap on it, a couple key things based on the patient's history: recurrent tender boils, recurrent painful nodules, draining scars. These are types of things that I think if I heard them on a history, even as a rookie, it would have triggered me to ask for photos if I'm not in office, examine the patient, and then refer onwards to the right people.
Do you see a lot of folks or patients complain about fatigue with HS?
No, but it makes perfect sense because fatigue and pain will go along with the fact that this is heavily inflammatory. And what happens in the body is that when you've got this heavy burden of inflammation, you get what you call, not to this degree, but something that's called almost like a cytokine storm. So you basically got all these inflammatory mediators in the blood, and they're going to war with the other anti-inflammatory mediators in your blood that are trying to calm it down. And that constant battle of all these inflammatory mediators from the disease and the anti-inflammatory mediators from the immune system, that is tiring to a person.
Yeah, it is. Was the medication one of the medications you were talking about prior, JAK inhibitors?
No.
Okay.
It's the anti-IL-17 category. So drugs are used in
Like
psoriasis.
Stelara?
So
isn't that an
Stellara's
IL-17?
Stelara is an anti-IL-12, 23. Stelara, anti-IL-17s, there's one called Cecchini, which is marketed as Cosentyx. There is Ixekizumab, which is marketed as Taltz. There's Bimekizumab, marketed as Bimzelx, and Brodalumab, marketed as Sleek.
And what do they target, towards HS?
So we're basically finding that in HS, well, we know that basics is that to drive neutrophil production, neutrophils are the cells that produce pus. There's two main pathways, amongst many other, that are early stage drivers of neutrophil production. That's TNF and IL-17. TNF was the first big target with adalimumab, Humira, and now we're finding that, lots of people don't respond to anti-TNF therapy. And I'm noticing my practice, we were discussing this weekend at a meeting when I was, it was a psoriasis meeting with some HS mixed into it, and I was explaining this as well. A lot of people I find now are not responding to anti-TNF therapy. And
is
when
that
happens,
sorry to interrupt you, is that just with the medication therapy alone, or is that in combination with the surgical intervention?
Well, just broadly speaking, I just find some people who are on like high dose Humira or on high dose Remicade, right? Like high dose, they're not responding. I'm sometimes switching them and putting them on an anti-IL-17 and getting changes like that. And
Really?
Yes.
That's amazing.
And what's happening? Well, this is what's happening. The body takes different paths to get to different places. And yes, the response rate in TNF therapy was quoted to be 40 to 50%, probably a bit more. It's actually probably a bit higher in my experience. That's still not a lot. That still means that half the people are either not really responding or not getting any response at all. So when I started managing more HS, I was keeping them on Humira or Remicade, waiting longer, increasing the dose. Now I'm giving it a decent amount of time, 6 months, a year max. And if there's no improvement, I'm changing, right? So there's no time. And the way I'm seeing my practice of HS management evolve is that we've got options. We don't have many, but we have got options. If something's not working, go back to the drawing board and reassess our plan of attack and try something new. And this is what I'm finding with the new drug categories that's coming. It's going to be coming to the market probably within the next year. When you fail one, give it a decent amount of time and switch, I'm often seeing improvement.
That's incredible.
That's really cool. Yeah.
How often are you seeing HS patients in clinic? Are you seeing multiple a day or?
Yeah, totally. Yeah. On Fridays, Dr. Ralph George and I will do our HS clinics, anywhere from 35 to 50 patients a day.
Wow.
On a Friday. And I'm actually seeing more HS now even during the week. So on Tuesday afternoons, I've got like another mini HS clinic where I'm seeing anywhere from 3 to sometimes 12 HS patients.
So like 6
I'm seeing more and more, and I'm trying to even I'm trying to get our clinic name out there even more to get more awareness. So, for example, my colleague Dr. Mike Sideropoulos has a small clinic that he's operating now out in Scarborough, just to let him be closer to home, just because he's just had a newborn. So he's working closer to home in a small makeshift clinic, but he's getting everything through his door. And he got a patient last week who was suffering greatly, and we squeezed her in today to see her, and I did it over FaceTime. And there's tons of people in the woodwork that are hiding all over the place that are not getting into the system. And one of my visions and one of my goals is to do more HS awareness with some creative ways that I've got planned, because I'm shocked at how those people have come out of nowhere.
I'm shocked that, GPs, gynecologists, first response medical professionals, in emergency rooms aren't being educated on this more, because we know that they can, if they did know, they could, first of all, diagnose, they could start an antibiotic treatment. So by the time patients did reach dermatologists like you, they're up to speed. And if they could go on a biologic or biosimilar or a different medication, and I think that would take a lot of the burden off of.
Totally. Yeah, you nailed it. You're 100% right. Look I know the system's not perfect. There's only 24 hours in a day. And everyone's doing their best. And unfortunately, there's small gaps that can easily be rectified. And maybe a dermatologist never offered to go to an emergency department and give a talk, right? Oftentimes it's just they would have never known because no one would have ever given them the opportunity to learn about it, right? What you don't know, right? So one thing that we can focus on is, when I've tried doing this with one of the hospitals in the area, is I can go give grand rounds, and we can give a presentation of like a rapid fire, high yield presentation of different skin conditions and make sure HS is at the top of that list. But I'm seeing this, and Dr. George will confirm this, is there are more and more surgeons referring HS patients to our clinic. And so there is awareness that is happening, but unfortunately, nothing's quick enough, nothing's broad enough, but with time we are making progress.
Awesome.
I remember the last time I went to an emergency room for something HS related. God, it was probably 10 years ago. But I had a doctor tell me that HS is a side effect of taking medications. So it, like 10
There's a
years ago,
gap.
there
There's
was
a
so
gap.
much misinformation.
Yeah, there's a gap.
Now when I have to go to emergency rooms, just because of my plethora of medical issues, I take a printout that kind of has a brief synopsis of what all my medical things are. And when I get a good doctor, they'll look it up before talking to me, so I don't have to then teach somebody about my own, medical issues before they come and try to help me.
So what we try to do with our patients, we try to encourage them to, not go to emerge, to, call our clinic. And we are really good with always fitting in our HS patients, especially with flares. There are plenty of amazing doctors that emerge as well, but I'd rather see my HS patients, and look at the flare and, do we drain it? Do we give some ILK? Do we cut it out on the spot? Do we give some steroids? Do we give some antibiotics? So I try to, encourage my patients to, that we have a safety net in our office, to make sure our patients don't fall through the cracks when there's a flare. And I kind of, and we squeeze these people in during the week to make sure that they're seen, that they need urgent care.
I do want to clarify, I don't go to emerge for HS. I do call your office. This is more for like the lung stuff and
Of course,
colitis when I end up in emerge. But for HS specifically, you guys are very, very good about seeing us quickly when we're flaring. So I do always contact your office first.
Yeah, I'm glad to hear that. And like I said, I know there's days where I'm rushed, where it might feel short, but just because it's short, we still care and we still will give you good care. But unfortunately, yes, there are days where, if we're squeezing things in, where there's a bit of, it's a bit shorter. I know that sometimes it's not the best feeling when it's rushed like this, but sometimes in medicine, we have to triage, we have to prioritize our time. And sometimes we got to get in, look at the problem, give a solution and keep going, right? Because there's someone else in the room next to you that also needs that. And so just to be aware of that, when you come to the office, yes, there are days where it's a bit quicker, but that doesn't change how we feel about what you're going through and the care you're going to be getting. That doesn't change.
I think it also puts it in a little bit of perspective, hearing that you're seeing some 60 plus HS patients a week, that, your appointment may be short, but you're still getting the care.
Yeah, we definitely see at least minimum 50 to 60 patients a week, minimum.
So you don't have a cap on your patient visits? Like in Alberta, we have a 20-minute cap on doctor visits. Do you have
No,
that?
but I try to cap, like there's no way I can spend, we can do the 20-minute visits with every, HS patient.
Right.
We definitely do spend time. But I think our cap is more so just our own time management. I don't think it takes 20 minutes all the time for the doctor to be there. I think that, I'm lucky that I'm very lucky. I've got the most amazing staff any dermatologist could ask for in my office. From my administrative staff to my office manager, my aesthetics coordinator, my research coordinators, my nurses, they're all fantastic. And they will often bridge the gap if I've had to move on with filling in with information.
So you've been at York Dermatology for 4 years, 5 years, 3 years, somewhere in and around there?
Do I look that aged already? Is it weird?
It's leading. I'm segueing into my next question of who is your most memorable HS case, or which case stands out to you in
Well,
time?
I've only been in practice for 3 years. I'm just coming on my third year now. And I've only been at York Derm for 2 years. It's going to be 2 years in August, actually.
Happy early anniversary.
Thank you. Time is, it's just, the last 2 years have just been like, it's been put into a vacuum and just gone, sucked away.
And in that time, who has been your, like, what case stands out to you in terms of HS?
It's hard to say. Like, it's tough to say because I've seen so much suffering over the last couple of years. It's hard to give one example. I recently had an 18-year-old boy who couldn't move his arms, and his mom had to help him do a lot of his stuff, and he spent 3 hours a day with his dresses. He could not move his arms. I've had patients who had surgery that we de-roofed, who said, I have not sat down at a dinner table for 14 years with my family.
Wow.
And then we'd done surgery and de-roofed. He's like, for the first time in 14 years, I sat at the dinner table.
Oh, wow.
I mean, the stories are endless. I can't give a memorable story because there's so much suffering that goes on that I've felt over the years. It's been a lot. And it's hard to give one example of one thing.
Do you find a lot of your patients struggle with range of motion?
Many, but not all. Range of motion seems to really come into play when it's an issue of when it's an issue of a flare. It's often with the flare they're more decreased. But like I said, I had some severe patients where they would come in stuck in a position. I've had patients walk through my door. A young female walking in the door with canes, and less than a year later, she's totally clear, walking in, all done up, just like night and day. But yeah, I have patients who come in on crutches or a cane, or two canes because they couldn't put weight bear, or the young gentleman that I mentioned whose arms were stuck in a position because he couldn't move. But for the most part, I usually find range of motion is decreased, usually because there's a flare.
You mentioned the use of canes, and I know that's strictly for HS, but I was just wondering, do you have a lot of arthritis that you see that goes with the HS in your practice? I have something called Sappho syndrome, so it's kind of a unique interest of mine.
Do you say Sappho?
Yeah.
Yeah, no, yeah, totally. That's also a very, very good question, and very high yield question, and I think merits an answer on the air. And the answer is yes. There is a huge burden of arthritis in HS. And what I think is happening is that I'm actually seeing patients who are coming in from rheumatologists who think these people have rheumatoid arthritis or other type of inflammatory arthritis, and they put them on their things like methotrexate. And
I got my Sappho syndrome diagnosis because of my reaction to Humira, which I was on for HS. Like I walked in to my dermatologist's office using the cane, because my back is so bad. On a Friday, they gave me Humira. On Tuesday, I was tap dancing in my doctor's office, going, "What did you do?"
Interesting.
It was completely night and day. It was amazing. Yeah,
because usually anti-TNF therapy can help that condition as well sometimes.
Well, yeah, she said that Humira originally started as a medication for rheumatoid arthritis, didn't it?
Yeah, it was used in arthritis and psoriasis.
And yeah, like I reacted really well with my HS did too, but the arthritis it was amazing. I wish I could have.
So when you say react, you mean responded well to the Humira?
Yeah. Oh yeah. Like my inflammation went down, my pain levels went down, my mobility went up, I felt 20 years younger, the best I had felt. Like it was, it was amazing.
Yeah, and that's exactly what I see, like this. So in the rheumatoid arthritis world, in the rheumatology world, anti-TNF therapy works very, very well to protect the joints. And in HS, it does help for sure, without a doubt. But just to add on to what I was saying earlier, the new category of drugs that will be hitting the market probably within the next year or so, they also do work very well in arthritis.
Oh, cool. Yeah, I'm now on Remicade because I had to go off Humira and it stopped working. But
yeah, I find like you said, Mike, a lot of people don't, or they'll lose response to anti-TNF therapy after a while. But the good news is that there's other things in the pipeline.
Oh, then you've given me hope if that day ever happens, or happens again, I guess.
Well, let's hope not. But yes, there's always another option, and that's what I'm trying to tell my patients. I said, this doesn't work. Don't lose hope or don't worry, because there are other options.
Cool.
Yeah, we had a woman write into us recently asking for our opinion. Her daughter was just diagnosed with HS, and after learning about it herself, she realized she and her sister also have it, and she's kind of just on the fence about how much information to give her daughter, or not wanting to scare her about the fact that it's a progressive disease. I was just wondering if you had any advice on how to educate a teen or a younger
preteen.
child.
Yeah, like
Yeah,
a young
a
teen.
pediatric patient on what to expect from HS.
I don't think, I would caution her on not using the word progressive, because it doesn't always have to be progressive. It's chronic, but it's not always progressive if you can get it early and combine it with the right types of therapy: medical, surgical, weight management, dietary changes, etc. I would approach it just the same way as I'd approach this with someone who has psoriasis or eczema. It's a condition that's inside of us that, we can control, and sometimes to a point of it being almost non-existent in appearance and feeling that it's there. But there are times where it might be a bit more active, and it might be a bit more of a problem or a bit more bothersome. And that will require a bit more urgent care with different medications or different procedures to get it back down to being where it was. And sometimes this is harder to achieve, and it requires multiple therapies, more frequent visits to see the doctor. But it's chronic, but it's not impossible to bring down to a level of normalcy, to normalcy. Because that's my goal with my patients. When they ask that same question, I say it is chronic, not always progressive, but chronic. And my goal is to try to restore you to as close as possible to a sense of normalcy.
And if we got diagnosed and had treatment at that age, it wouldn't have been progressive for us either. So
I can't guarantee that. It's hard to say. You're right. I agree with you. But yes, more likely than not, no. But there are possibilities of some difficult cases where it is slowly progressive, right? But yes, I understand where your perspective is. Yes, if you had got it earlier, then the chance of progression would have probably been limited much further than if you were undergoing treatment. Totally.
Maybe could have avoided some of the medical trauma that we all have in our
and there's that as well,
history.
Yeah.
Maybe on a bit of a lighter topic, we talk about like HS and summer heat, and what is it about heat and sweating that causes flares for people?
Right. So we know that this is a condition that affects the skin of sweat gland bearing skin, and and during the summertime, or even with exercise, for example, there's a couple different things that are coming into effect here. So one of the things you have to remember is that in the heat of the summer, there's going to be when you're walking and sweating, there's often more chafing. So the rubbing alone will irritate the skin. That is one important factor. The other important factor to remember is that during the summertime, you shower in the morning or at night or whatever, and you sweat during the day. And when you're sweating, there's always and you're producing more of the. In this sweat, you've got some of the fatty acids and the fatty substance on the skin, like the oils on the skin. That in turn will allow bacteria that live on the skin that are harmless to become a bit more active. And when I say active, I don't mean cause infection, but they become a bit more active and they produce a bit more of an inflammatory response. And that inflammatory response is usually enough to trigger the skin in the areas that are already very sensitive to inflammation, to act up.
Yeah, I had to stop wearing my ball cap when I go for my walks with my dogs every morning because I've had surgery on the back of my hairline here, and the rubbing and the sweating was starting to make me flare a bit, so I've just had to stop. But I do like wearing a
Yeah,
hat for sun protection.
yeah, that's the unfortunate thing, right? Is it's hard in the heat with wearing tighter things or like I said with the chafing, right? Whether it's skin on skin chafing or wearing tighter clothes. So usually what I suggest is wear looser clothes, very breathable clothes, cotton underwear. Males, not wearing those dry fit boxers, with the synthetics, and wearing the cotton, breathable underwear, looser pants, linen, things like this, so the skin is more breathable during the summer months.
I know.
Cotton really is the fabric of our lives in the summer.
Here.
So we do have very sensitive skin. What's the best kind of way to protect against sun exposure? Are there certain, I don't want to make this about brands, but are there certain brands that are maybe our skin can tolerate better than others?
Well, we don't actually have to go into the brand question, to be honest. We could, the best thing that I'd recommend usually is a mineral sunscreen. So there's two types of sunscreen. There's a chemical and physical. Physical sunscreens are the ones that physically block the sun rays with the bigger molecules, like minerals. So titanium dioxide is a popular one, for example. So most brands now, almost all brands, will have a physical option, like a mineral sunscreen. I would stay away from brands of chemical sunscreens like Banana Boat, Hawaiian Tropic, these types of things, for a couple of reasons. First one being that they're chemical sun blockers, but they're also full of a lot of irritants in them. They smell great. I used to love Hawaiian Tropic when I was younger. But in terms of their actual effect on the skin, I think a lot of those irritants could actually trigger an HS flare or irritate the skin that's already sensitive in your condition, as you mentioned. The other option as well is physical things. So sun protective clothing, right? You can buy long sleeve protective UV clothing, hats, sunglasses to protect the eyes.
Have you noticed, or has any of your patients brought to your attention that they burn far easier if they're on a biologic? I'm on Remicade, and I feel like no matter how much sunscreen I put on, I'm burning in the sun.
I do not think that people have ever brought that to my attention yet.
I was out last weekend and I had like SPF 50 on. I was wearing baby sunscreen and I still burned, like not badly, but enough that it caused irritation.
That's a good question.
Did you reapply your?
Yeah, it was like constant reapplying of the sunscreen. It's just I couldn't avoid.
I would try using a physical blocker, like a mineral sunscreen instead of chemical. Okay, so mineral sunscreen instead. It produces it's more of a barrier. Okay, it produces more of a barrier.
And so, like, just talking about it, is that like sprays are kind of a no-go? It's more of like
it's the creams, but it's not the old school ones that you put them on. It's like a white layer, like they're all tinted now. So it's not the original mineral sunscreens where you put it on and you just look like a white, like a mummy. Like that doesn't exist anymore. But a physical blocker, like mineral sunscreen, would be best.
And is it zinc sunscreen? What is the one that's kind of an orangey tint? Crystal, do you know what I'm talking about? I feel like we've talked about this.
I don't even know if they make that kind anymore. Like the one that the doctor was speaking about, I've seen they come in like sticks and you're supposed to like put 1, 2,
Vichy,
3
so
and then
I know Vichy Sport. Oh, orange like the bottle? Or orange color of the sunscreen? Which one are you talking about?
Like it's like a orangey tinted sunscreen. I feel like
I don't know about the orange tinted one, but the tube that Crystal's talking about, like Vichy Sport, Vichy has a sunscreen stick that's in an orange tube, but not an orange sunscreen. Or I don't know the colors offhand, but I know that Vichy spreads a yellow-orange tube.
And the mineral's better for skin of color as well, because you're not putting the white sun block. The mineral stuff isn't like that. It doesn't leave like the white.
It's tinted now. I know there's quite tinted sunscreens now, even for skin of color, that blends quite nicely.
Interesting.
You know, a lot of people are away in the summers. Do you have any kind of maybe at-home tips for people to help get their HS abscesses to come to a head, or if they don't have the option of coming in because maybe they're not close to the office?
So a couple things I'd recommend is plan ahead. So before a trip, come see us. Hey, look, at these are my summer plans. I'm taking off for however amount of time. And then what I would recommend, this is what I've been doing for my patients who are doing trips, is I'm giving them rescue drugs to go away. So topical stuff, like I use a lot of clindamycin with either Elicon or clobetasol that works very, very well topically with the soak. I'll give them a script for a rescue antibiotics in case things go wrong on a trip. Even sometimes for my patients who are very involved with their care, I'll give them a small dose of prednisone to take with them for flares to keep them under control if anything goes wrong. If you're in a 12-hour plane ride to India I'll make sure that you're going to have something to go away with. I'll give you some pain control as well, so I'll give you a couple tabs of Toradol or other things like this to help with the pain if there is pain as well. So the biggest thing that I'd actually recommend is plan ahead. Is come and see us. Even a phone call. We can even do like a virtual phone call before you go away just to check in. But if you're away and you don't have access to it, you can always go to a walk-in clinic, or even in different countries, you can always just go to an urgent care clinic. But in terms of at-home things, a warm compress. But oftentimes I find when people squeeze these lesions or they squeeze like a nodule or an abscess, I find that squeezing alone usually increases the inflammation and actually often makes it worse.
Yeah.
I remember I was away. I was just in Wasaga, so I guess I could have driven back home. But my sister suggested a hot tea bag in a baggie just to like spot heat the.
So actually, a tea bag on the skin would actually be better directly on the skin.
Oh, okay.
The other thing that actually works quite well is Epsom salt baths. So wherever you are, there's always a pharmacy where you can go buy Epsom salts. And soaking in those, I got a patient who swears by them, and she's actually the one that taught me that, because she was showing me the difference. She's actually participating in one of our clinical trials, and she was showing me the difference of when she soaks and when she doesn't. And actually, the difference is actually quite remarkable.
And what about bleach baths? Because I know that comes up a lot on like patient groups.
Yeah,
nobody's really like 100% sure on how to do them.
It's an older thing that was around a while ago for treating eczema. I think it's fallen to the wayside a little bit. I don't support it. I don't condemn it, but I don't support it at this point.
I was going to ask something real quick. We've had a few patients ask this recently too. Lots of concern about odor from the flares. Is there anything that you suggest to help with that?
So that one's a tough one as well. What you could do is you could use like a very natural type of deodorant or antiperspirant that has a bit of scent in it, and you can put it around the areas. But again, warm compress or gentle washing. You want to avoid things like spraying like Axe body spray or something like that, because it's just going to be very, very irritating. Same thing with putting a deodorant stick over top of it. You don't want to irritate it. You don't want to block up the channels that are allowing it to drain. But you can put it around the area, or if needed be, then you can also just put like a dressing over it. But the way you're going to actually decrease the odor is by seeking care. Getting on antibiotics for rescue, getting on a long-term therapy. Having the area cut out. Right, I've been trying to identify and cut out more areas where there's a lot of thick scarring drainage, because I can often completely normalize that area if I can just cut out that one spot of recurrent drainage, because you get all normal skin around, you close it up, and it's a done deal. There's no more anything in that area.
By cut out, are you meaning like de-roofing?
No, so what I'm actually doing is that there's some areas, especially in the armpits, if there's a bit more skin laxity, or in the groin, is I'll cut it out and I'll sew it back nicely. So all you have is a nice thin little line. So scarring, the nodules, the tunnels, everything that was there in that one area is gone and sewed up and brought the normal skin together that's healed with a nice line.
What's your reoccurrence percentage with that?
So the recurrence is actually quite low. I'd say it's probably, I think in the literature it's around 10 to 15% recurrence, which is quite low. But the people that I've done in the office have had, I'd say that's probably even less than 5% with our success rate. Or what I'll do is I'll do it staged. So I'll do, if it's a large area, I'll cut one area out, I'll sew it up, I'll let it heal, or I'll let it heal by second intention, and then I'll cut a second area out, and then close it up and let the skin stretch and do it until the whole area is gone. So that's beneficial sometimes for those who don't want to go into the operating room. There's long waits to get in the operating room. I'm finding a lot of success with doing these staged excisions, cutting and closing until the area is basically normal.
So you just do like a local with that?
You got it.
What's healing like for your HS patients? Because I know many of us struggle with complications after the fact and how we're healing.
So de-roofing or wide local excisions that are left to heal by second intention is very, very painful. Very painful. It's a long road. I'm finding that with the importance of doing surgeries, like when Dr. George does a big surgery in the operating room, for example, key things is sending home with a rescue script of antibiotics, pain control, which doctors unfortunately are way behind in doing, and we're working on getting better. So I'm very much aware of the pain factor with my patients. So I'm also I'm always providing something for pain relief post-operative, but also educating patients on what to know. So if the wound is left open, like to heal by second intention, it will be very, very wet and it will drain a lot. Okay, and that's the results of the fat, which is very high water content, drying out.
Do you keep
granulating?
Do you keep your de-roofings wet? Like I know the ones I have to be constantly packed with Vaseline because they heal quicker wet, and they're also less painful.
Fair, there are pain, but oftentimes post-operatively people will often get lots of discharge in their band-aids from the fat drying out. Keeping it moist is important, because what happens is the skin cells actually roll, and that's how they actually grow. So it comes from the bottom up, and then in the top, the skin cells actually roll closer together, and that's how it closes. So that skin needs to be moist for sure. But often at the bed of the wound, it's often more wet, often too wet, and patients will often complain of lots of drainage, but that's normal. Okay, things that are not normal is like lots of drainage that might become yellow, malodorous, increased pain in the area, because that would be the sign of an infection. But it is normal for a normal secondary intention wound to have drainage and discomfort. I prefer to close my wounds when I can. I find that the healing time is a matter of weeks as opposed to months. It's a lot quicker, less pain, and a nice cosmetic effect. But there are areas that are too large that that I'll see with Dr. George, and we'll have a discussion, and we'll realize that it's a little bit too much to close, and secondary intention is the best bet. So it really is patient dependent and case by case dependent.
Are you guys utilizing ultrasound machines when you're doing these surgeries?
So I have an ultrasound device that I purchased to identify tunnels and whatnot. But I'm not sure, ultrasound.
No, I've seen like a handheld, like small one that's in the States I've seen as an example, and they can actually go in and see how deep the track is instead of going in blind.
Yeah, so we have that. We have that at the office now. I have the handheld device. It's actually called a Butterfly, and we plug it into a big screen that we purchased, and we're able to actually visualize underneath the skin.
And does that help you determine what sort of surgical intervention you're going to choose by being like, that is so cool that you can see that, because I've gone in so many times, and you never know what's in there until you open it up. So being able to know ahead of time is pretty awesome.
It gives a bit of it gives a little bit of an added perspective. I agree, but oftentimes I'm finding alone with the tunneling is I often do well feeling. You can feel with your fingers in them, and once you're in the skin and once you're cutting, you can often see it if it's in an area that's not complicated. Especially the complicated areas I find are in the groin, but in the armpits, the thighs, under the breast. Those are usually quite straightforward and manageable without. But yes, it does add a little bit of extra. Visualization to the area.
Okay. Thank you, everyone, for joining us today, and a special thank you to you, Dr. Cecchini, for the care you provide to HS patients and the information you shared with us today. Join us next month for another episode of the HS Heroes podcast. And until then, remember, real heroes don't wear capes.